Hello, everyone. Welcome to DocTalks. I'm Dr. Manju George, the Scientific Director at Paltown Development Foundation, the nonprofit that supports colontown. Thanks to Laure for organizing this and to Dr. Sgarbura. So what we will do is that we will first go around and introduce the panel. And then as Dr. Sgarbura has, the agenda, we will go according to that. So let's start then.
Good evening, everybody. It's it's an honor to be here and to meet you all and to organize this webinar, especially with this panel. So my name is Olivia Sgarbura. I'm a surgical oncologist at the Institute of Cancer in Montpellier.
Okay, then Dr. Hübner, do you want to introduce yourself?
Sure. So it's also a privilege for me to be invited here, and I'm very curious. I'm a colorectal and oncological surgeon at Lausanne University Hospital.
Okay, thank you. Dr. Klempner, do you want to go next?
Yes, also happy to be here and making a slight deviation into the lower part of the GI tract from the stomach. I'm a GI medical oncologist at Mass General in Boston.
Okay, thank you. Dr. Gongura, do you want to go next?
So I'm Celine Gongura. It's really a pleasure for me to be here. I'm a researcher. I'm working in Montpellier, France. And so I will give you some new events and some new models on the research for colorectal cancer and peritoneal metastases.
Okay, thank you very much. As Dr. Klempner is sharing his screen, when you hear the talk and you have questions, please type them in chat, and then we will go over the questions after each section.
All right, so I think I probably have the least exciting part of this. I know everybody's always very interested in the newer surgical techniques and the new translational models, but I'm going to sort of walk through the standards, because I think it's always important to have a sense of starting from the same place and understanding what sort of the standard management is. So these are my disclosures. Some stuff I get paid for, some stuff I don't. This is a reminder of what we're talking about. I know that this audience is probably particularly advanced among patients and caregivers, but sometimes explaining the peritoneum is not so straightforward. So I'm still working on the best analogy, but if you think about it as a wall, the front of the wall, like what you see, the drywall, is the front of the abdomen, and then there's this space, and then there's the backing. And this is sort of an easy way to think about it. Another way I've thought helpful is thinking about meat at the grocery store, where there's this very shiny layer of saran wrap over the meat, and that's kind of like the layer that all of the guts are wrapped in the abdomen, the peritoneum. And it's a coating thin layer over most of the organs. So this is obviously a person cut in side view, and you can see sort of what this looks like. You have this layer of saran wrap that's really wrapping all of the organs in the peritoneum in a very tight layer. And that's where when we're talking about disease in the peritoneum, we're talking about things on top of the saran wrap that aren't really supposed to be there. There's a lot of really interesting biology that we're still learning, and others here know more than me about this. But if you think about tumor cells trying to live in this environment, it's quite different than some of the other environments like the lymph node or the lung or the liver, where there is more of an established sort of soil for these tumor cells to live in, with blood supplies and other organ function. In the peritoneum, tumor cells have to adapt and make some changes in order to survive. And some of these are the ability to basically initially circulate around in the peritoneum and then stick on to the surface of that saran wrap, and then hide from the immune cells that job is to sort of monitor for abnormal cells, and then grow. And so these are several steps that are required for these tumor cells, and we'll probably hear a little bit more about this in the talk later on, so I don't want to spend too much time about it. But it's a really important property, and it's probably one of the reasons why peritoneal disease behaves somewhat differently than disease in other locations. When we see someone with new involvement of the peritoneum, whether this is recurrence from a stage 2 or 3 cancer that has come back, or whether like some percent of patients, they presented and the first time they found out about their cancer, they had peritoneal involvement right from the get-go. So in general, I think it's important to have some of these important shared decision-making. And this is just a framework for thinking through all patients. This could be for any cancer. So we have to all be on the same page about our goals. We all want to prolong survival and palliate symptoms and make quality of life good. We do want to follow evidence, because just because we can do something doesn't mean we should. We have to be really transparent about what are the expected outcomes. If someone's going to go through a big operation, say a cytoreductive surgery, you know, we have to be all on the same page about what are the expectations realistically. And then we have to continuously reevaluate this for all of our therapies. This is probably an oversimplified slide for this audience, but I think we use a lot of jargon and talk about first line and second line and third line all the time. But when you're diagnosed with advanced colorectal cancers, first line is generally the first chemotherapy you get. And then at some point, if that starts losing its efficacy and it needs to be changed, you go on to second line therapy and so forth. And so these are the most common combinations used in the front line: FOLFOX, FOLFIRI, and then increasingly FOLFOXIRI. And the choice among these depends a little bit on the goal. Some drugs, when you combine more drugs, you get a higher response rate, but you also get additional side effects. And then all of these can have biologic agents, so non-chemo drugs such as bevacizumab, cetuximab, or panitumumab, added based on the tumor biomarkers. And we'll come back to that in a minute. So why are we even having this talk? Why do we talk about peritoneal approaches? So when we give chemotherapy in the veins, it is generally less effective in the peritoneal metastasis than in other metastatic sites, such as the liver, lymph nodes, and lungs. And this is something that we've learned over the years with the help of our surgeons and everybody else. And there's probably several factors that explain this. Simple ones may just be drug access and penetration into tumor cells from the vein when the cancer cells are sitting on top of that thin peritoneal layer. Obviously, that led to the obvious idea of, what about putting it right where the money is, as in into the abdomen? And this is sort of one of the underlying principles and hypotheses of all peritoneal-directed strategies, that we could improve exposure of drug to the tumor cells and therefore improve the chance that we can kill the tumor cells in the peritoneum. And similarly, in the same vein, if our therapies in the vein are less effective in the peritoneum, maybe we should try to debulk the tumor out of the abdomen, so that if our therapies are less effective there, we can continue our good systemic therapies, but have other tools to manage the cells in the abdomen, which are less responsive. So these are sort of the overarching principles. I want to dive a little bit deeper into some of the updates we've had. So this is from 10 days ago at ASCO GI, and this is a series from MD Anderson in the US. And essentially, they looked at all colorectal cancer patients. So these are all patients who have peritoneal metastases. And then they were looking back to try to understand, if we know something about the tumor, can we understand the biology a little bit better? So for example, if you have a BRAF mutation, you are less likely to do well with your peritoneal disease than someone who has peritoneal disease and no BRAF mutation. The reason I'm highlighting this is that the more we understand about each patient's individual tumor, we really want to start to use more and more of this information into thinking about our decisions about who's the right person for peritoneal-directed strategies. If someone has a really aggressive biology, just that's the way the tumor is built, it may be a more difficult situation or potentially a higher risk situation to undertake a very large and potentially high risk procedure. So we want to really understand as much as we can about the tumors. This is a similar effort, largely from a Dutch group, looking at colorectal peritoneal metastases, again, trying to understand the biology. So what you're looking at here in the top left is primary tumor, so the colon tumor, versus peritoneal metastases. And immediately you can see that the green bar is much bigger in the people with peritoneal metastases. And the green bar represents a subtype of colorectal cancer called CMS4. And you don't have to remember that, but CMS4 is associated with some more aggressive biology, less sensitivity to immune therapies, high levels of TGF-beta, which is an immune suppressive factor. And so we're learning a little bit more about what are the types of cells that are living in the peritoneum and what adaptations have they made. And then we look at mutations over here in the bottom left, and you see that there's an enrichment for KRAS alterations in peritoneal metastases. And these are also features that are associated with a little bit more aggressive biology. All of this is just to say that we're learning, and now we're really studying this in a better way to understand more about the biology of peritoneal disease and how is it different than the primary tumor or a liver metastasis. This really highlights maybe one of the key points of this whole sort of intro-like talk is that peritoneal disease, just like the rest of colorectal cancer, is becoming a disease of subgroups. Over here is the standard tools, chemo, standard biologics, other chemo drugs, but now it's really all about the right side of this story now. For example, we don't really know if someone who has a HER2 amplification in colorectal cancer, our newer drugs are quite good at targeting HER2, and there was just an approval for a new combination 10 days ago. So if someone has a really actionable or a tumor type that's very likely to respond to our good therapies, is that someone that we should think about maximizing the systemic therapy before we think about peritoneal directed strategies? So again, the point is really that we need to understand our tumors as well as possible and start to factor that into thinking about peritoneal disease. Again, a lot of people ask about what is the standard. Well, the standard of care for managing colon cancer with peritoneal metastasis is systemic therapy. That has been the standard therapy for a while, whether this is FOLFOX or FOLFIRI or FOLFOXIRI or whatever. The surgeons have done some beautiful work, and I think we're getting closer to understanding about who are the people that may benefit. But to date, in our medical oncology perspective, we have yet to see a very large phase 3 trial that has reliably shown survival in colorectal cancer with peritoneal disease. There are some very nice trials that suggest groups of patients, but as we get better at modern chemotherapies and combinations, we are actually doing a little bit better overall. There is a future here for sure, which involves novel therapies into the peritoneum. So you can give oncolytic viruses, and here is an example from a clinical trial that's published a couple of years ago, and this author continues to build on. And then there's a lot of other immune therapies, including drugs like immune checkpoint inhibitors, consideration for right into the abdomen. There's a trial in Singapore looking at nivolumab, Opdivo, given into the peritoneum with intraperitoneal chemo for gastric cancer. And I think we'll start to see some and more of these strategies coming to colorectal cancer. So again, I think it's about patient selection. That's one of the key themes. And this is from the PRODIGE 7 trial, which we may hear about from the surgeons, but it was looking at essentially the amount of cancer in the abdomen, among other features here, as identifying groups who might do the best. So here's everybody gets surgery, some group gets HIPEC, the other group didn't get HIPEC. And then you say, if you had a lot of cancer in the abdomen, so a PCI score that was over 15, your average degree of benefit from HIPEC was minimal. Whereas if you had on the lower end, and some of these numbers here are relatively small, you may be more likely to benefit. So again, it's just pointing us towards the idea of patient selection. And I come back to this theme of just because we can doesn't mean we should. So I think that's the end of my talk. It's really a high-level summary of improved biologic understanding. We know peritoneal disease is a big problem. We need to do better. There's no doubt about that. We need help from our scientific colleagues to make better models to understand the biology and test whether someone with HER2 positive disease really is getting the same amount of benefit as someone with HER2 negative disease. We need better drugs and better delivery. So thinking about other tools into the abdomen, and then really patient selection in clinical trials, really picking the right people to give these therapies the best chance of working. I think that's been one of the criticisms, is that the populations of patients in the trial are very mixed. And so there's clearly some people that benefit, but maybe on average, we haven't been able to prove it. So I will stop there and very interested to, this is where I like to spend the rest of my time, on the farm I grew up on. Happy to take questions at the end, and I will turn it back to Dr. Sgarbura.
Thank you, Dr. Klempner, for that great presentation. I was wondering, since you have to leave, can we take some of the chemo-related questions right now? Is that okay?
Yeah, I can stay for another half hour or so, so whatever you prefer.
Yeah, let's just quickly go through this, and then we can do the other sections. Dr. Sgarbura, is that okay with you and the rest of the panel? Okay.
Definitely, for me, it's okay.
Okay, I think we can start from the top. Like the surgery questions we will leave for later. One of the question is like, is a combination of KRAS G12C inhibitors with Cetux recommended for appendiceal adenocarcinoma? I mean, this is a little bit, away from what we are discussing, but if you can provide an answer, that'd be great.
Yes, I think it's all coming back to the same theme. So KRAS G12C is a very hot target in all GI cancers that have that mutation, but G12C is a mutation for which we have drugs that can target directly, and a lot of this is published. But in patients and in tumor types where there aren't clear standards, like appendiceal cancer, for example, from a chemotherapy standpoint, I would very quickly try to reach for and offer a G12C combination to a patient with appendix. Ideally on trial, these drugs are not yet approved broadly, approved for lung, but not yet colorectal and appendiceal. All of us at academic centers are lucky enough to have these trials. And so I know actually one of a patient on this call currently has benefited from the strategy. So I can tell you that, yes, 100%, I would be looking to try to get G12C for someone in that scenario. And I do think combination is the way to go, like with cetuximab or other combos.
Okay, the other related question is, KRAS G12C inhibitor with Avastin. Do you think that adding Avastin is a good idea for perimets?
Yeah, I do. I think we don't have much data there, but I think that the G12C agents broadly work better in combination than alone. We don't know exactly what's the right combination. You can make a case for Avastin, you can make a case for cetuximab, you can make a case for immunotherapy. But I think in peritoneal disease, we have seen some benefit for Avastin, at least in patients with particularly fluid accumulations like ascites. So I do think it's a very reasonable combination.
Okay, thank you very much. The next question is, do we know why TGF-beta inhibitors do not work in CMS4?
That is a great question. I think it remains a very attractive target based on the biology. Some of it is maybe our failures as drugs, including the optimal way to target, and also more deeply the understanding of the biology. Just removing TGF-beta may not be enough to sort of reorient the tumor towards response. You probably need to do more than just that. So I think that a lot more to come. The best strategy to target TGF-beta, whether it's soaking up the circulating factor or inhibiting the receptor using a small molecule inhibitor, is not known. There are several trials still doing this. Novartis is actually doing a very big, I think, phase 2 or phase 3 trial in colorectal cancer with their TGF-beta drug. So I think we're going to learn a lot more, but it's clearly not a one-size-fits-all.
Okay, thank you very much. And then the next question is, when it comes to looking for new mutations to guide treatment in perimets, should we use tissue biopsy versus liquid biopsy? Is there, is there a preference, and why?
Yeah, interesting question. So people with peritoneal disease, for whatever reason, don't tend to shed a lot of circulating tumor DNA. And so a lot of times the drawing a blood test will not have adequate amount of circulating tumor DNA to either perform the test or have high confidence that you're seeing all the alterations in the tumor. So when possible, we do prefer to try to get a tissue sample from the peritoneum and do the sequencing from that. It's not always possible. So sometimes we wind up doing both. But if I had to pick, I would choose tissue. If tissue wasn't possible, then I would try the blood, understanding that it may not be as complete a picture.
Okay, I'll ask one broad question and then maybe we can go to the next section. So with peritoneal disease, if you look at very broadly, when you're counseling a patient, what would be the broad goals of care? Is it just removing that? I mean, what would it be with respect to, quality of life or delaying the inevitable? Like, how would you think about the whole process?
Yeah, I think this is really a question probably for the whole panel. Maybe a good one for the end of the talk when we've heard from everybody else. But I think there's a lot of things you can do, and the goal of the patient and the physician are very important. Sometimes it's palliating a symptom. Sometimes it's reducing accumulation of fluid. You can do laparoscopic HIPEC and things like that. Sometimes it's going for one of those long-term durable remissions or even cures, which we know can happen. It's really just about finding the right patients and matching it to the right strategy. But I'll maybe save the rest for the end. That's a great question for the end, I think.
Okay. Then there is another related question. So you talked about the oncolytic virus trial and similar trials, right? So again, from the patient point of view, who would be an ideal patient for such trials? Like, what should they think about when they're, looking at these trials?
So I think that basically anytime we're doing something that's not proven, the best way to do it is on a trial. And so I think you'll hear from all the surgeons and everybody else that, most of their work is done in the context of a trial. And where people think that the trial evidence is good, we start to do that outside of a clinical trial. And certainly that's generally how we do the same thing in medical oncology. Patient selection, I mean, if you have a biomarker for the virus, like it targets a certain expression protein on the surface of the tumor cell, like CAR T cells do, then obviously patients who have that target are going to be a better group of patients. If the virus seems to work best when there's a lower burden of disease, then you probably want to think about people who have not an abdomen that's totally full of cancer, because that may not be the right choice. And then, of course, we need to do the trials to understand like who are the best populations, because sometimes we go in thinking and then we're proven wrong. It's actually someone who has peritoneal disease and no liver metastases and box check. So I think, I don't know that I know the answer to that question, but broadly it depends on if they have the target of the strategy, and I think disease burden is important.
Okay, thank you very much. So maybe then we can move to the next speaker, Dr. Sgarbura.
Thank you very much. Thank you, Dr. Klempner. I'm really sorry about my voice, so it's not really in its perfect fit, but I will try to do my best and present properly. Let me share the screen with you. Okay, so we'll try to talk a little bit about surgical treatment now. I have nothing to disclose, and you've already had a very, very good description of the peritoneum. How does a patient get peritoneal mets? Well, the tumor is very bulky, is very voluminous. Some of the cells are detaching. Some of them might go into the blood circulation, and they might eventually lead to lung mets or liver mets or lymph node mets. And sometimes they are detaching outside towards the peritoneal cavity. And in that case, they will follow the flow into the abdominal cavity, which means that they will start fixing themselves either on the omentum or on the peritoneum from the diaphragm, which are the sites probably most frequently involved in this situation. What makes them hard to treat? So you've already heard quite interesting information from Dr. Klempner. There are several things that make them hard to treat, but biological characteristics are something to look into. There is a description that was done in the late 80s, and that probably needs to be re-challenged now with professional and modern technologies. But this description shows that there would be a plasma peritoneal barrier that prevents the transpassage of intravenous drugs into the peritoneal nodules. And this explains, on one hand, why when we are treating the patients with systemic chemotherapy, it might not necessarily lead to the diminishment of peritoneal nodules, and the other way around, why it might be interesting to perform intraperitoneal chemotherapy, and because it might not be accompanied by high systemic effects, as it will not go back into the blood in high quantity. As you've seen, they're quite frequent. So this is a problem, quite an important problem for patients with colorectal mets. And sometimes when they appear metachronously, that means from a certain distance, more than 6 months from the primary tumor, sometimes they are difficult to detect because peritoneal nodes are usually very, very small tumors. They are often less than 1 centimeter, even more often less than 5 millimeters. And we know that more than 50% of the lesions less than 5 millimeters are invisible at CT scan. So I chose this imaging from a recent review in a journal from the Nature group. So it illustrates quite well that we see some of the things when the nodules are big, we see them with different imaging techniques. So number one is a CT scan. So this is a longitudinal vision of the human body with the liver here, the spleen over here. You can see the major blood vessels and so on. And where you see the arrows, there is evidence of some nodules either in the omentum or in the paracolic gutter. You can see the same, but maybe smaller in size at the PET scan, positive emission tomograph. You can see the same in the MRI, but actually you see no evidence of disease on the small bowel. But sometimes when we open the patients or when we perform surgery, we do see the small nodules on the bowel. That means that imaging techniques used to underestimate the importance of the disease, and that always we can have some surprises. We are estimating the extension of the peritoneal mets using a peritoneal cancer index. The maximum score is 39. So this is some in colorectal, in the specific setting of colorectal cancer. This is a resectability criteria. We have a definition for a threshold of 17. This is quite a relative value. It was shown on a monocentric series, and I think it can be challenged by some other factors that are important for resectability. You've heard some of them in Dr. Klempner's presentation. We are taking a look at the histological subtype, whether this is a Lieberkühnian subtype or a mucinous adenocarcinoma. Mucinous adenocarcinoma usually has larger peritoneal nodes with a lot of mucin inside. And we might extend our surgical indication to higher PCIs because usually the lesions are easy to detach and we can spare a lot more organs. Other factors that might be important are the presence of synod ring cells. We probably have lower resectability threshold for synod ring cells. Mutations are also important in some of the cases, and molecular subtypes are not really a part of the clinical decision now, but probably will become in a way in the future. Also from the same Nature review I presented earlier, you can see that many factors are related to the resectability of the disease. Some of them are, of course, related to the peritoneal disease per se, as I told you earlier, to the tumor factors, but some of them are simply related to the patient's condition, and of course to the experience of the surgeon and of the entire team in the center treating the patient. So probably this will be an oversimplified representation or summarization of how we might treat a patient with peritoneal mets. Depending on the extension of the peritoneal disease, we might perform an induction treatment. So usually a first line of metastatic chemotherapy, as you've seen also in the presentation before. After that, we might want to perform the cytoreductive surgeries if the patient is eligible, add or not add HIPEC, and we'll talk about that. And probably there would be adjuvant treatment after that. So our part is really in the middle, I would say. Most of the time it comes after systemic chemotherapy in very rare cases and some country-specific situations where cytoreductive surgery might come first. But as the middle is our role, I will focus on that. And I would just start by saying that cytoreductive surgery needs to be complete in order to be beneficial. Because otherwise, if you leave too much tumor behind, if we leave any tumor behind, it might get into all the places where we try to dissect. So that's bad. Therefore, it should be performed in an expert center. So the learning curve, it's important. The threshold, so that would be the number of cases performed per year. It's important also because the team needs to stay trained to this specific procedure. And when I say the team, I mean the surgeon and their team, but I also say anesthesiologists, medical oncologists, and so on. So of course it should be discussed in the tumor board in order to find out the optimal way to articulate that with systemic chemotherapy. And we sometimes choose to provide HIPEC, and of course it will come back to that. And the idea of HIPEC is to destroy the remaining invisible disease. Because when we take out the tumor burden from the peritoneum, we try to be complete as far as our eyes can see. But as you've seen, sometimes cells can be detached and they might go through the abdominal cavity. And HIPEC was born from the idea of killing those cells before they get back into circulation or they fix again. So one of the randomized controlled trials that tested this hypothesis was born also in Montpellier. It's my mentor that you see in the photo, François Quinet, who was the principal investigator of the Produce 7 trial. Once the complete surgical resection was achieved at the operating room, he randomized the patients with HIPEC versus without HIPEC. But the HIPEC he chose at the time was the one that was proved interesting in France. It's oxaliplatin-based, high dose, short duration, so 460 milligram per square meter during 30 minutes. And there was no stratification of PCI. This was not known as a prognostic factor by that time, but there was stratification on other factors. And these are survival lines. So the two lines with HIPEC and without HIPEC are perfectly going together throughout the time. So which means that there is no difference in survival between the patients that received HIPEC and those that did not receive HIPEC based on oxaliplatin within that study. But as you've seen already in Dr. Klempner's, there is this subgroup of patients with intermediary PCI, so an extension of the disease that is not very small, but not very important either, sorry. And in this group, there would be a signal that might favor HIPEC. So the idea of the entire community of HIPEC surgeons was that if we did not get a huge benefit in this trial with oxaliplatin-based HIPEC, maybe based on retrospective studies, other types of HIPEC might work. So we might, of course, perform a good cytoreductive complete surgery and propose it without HIPEC to our patients, but there might be situations in which HIPEC could be interesting. And therefore, international consensus for the use of HIPEC in peritoneal surface malignancies took place in the last through the last 2 years. You see here the core committee, and then there were disease-specific committees. It involved 145 experts throughout the world, and their opinion concerning HIPEC in today's practice is that it could be interesting after primary cytoreductive surgery, and it would be also interesting to late recurrence after cytoreductive surgery. And their regimen of choice was mitomycin based. So that means that the dose of mitomycin C we propose is 35 milligrams per square meter, but it should be administered during 90 minutes in 3 fractions, half of it first, and then a quarter of it every 30 minutes. For patients that are not eligible for surgery for different reasons, so mostly of them is high PCI, or even if the PCI is not that high, but diffuse diseases can be found on the serosal surface of the small bowel. A second line of chemo is, of course, of use, and a new drug delivery technique in the peritoneum called PIPEC, pressurized intraperitoneal aerosol chemotherapy, was proposed as something that could be administered alone or in association with systemic chemotherapy, usually beyond the second line, in colorectal cancer, because as you've seen earlier on, we've got a lot of lines that can prove themselves useful for these patients. And we did a consensus on what type of PIPEC, what type of molecule we should use with PIPEC in colorectal cancer. So oxaliplatin was found as a good PIPEC drug. And then my colleague, Dr. Hübner, gathered the cohort, the international cohort for the use of PIPEC in colorectal patients. And we've seen that there is quite an interesting response in terms of diminishment at the radiological imaging, histological response, and even sometimes in terms of symptom control. And there is some sort of survival benefit as well, but of course the cohort was a bit large and a bit heterogeneous to finally conclude on that. Similarly, there is response on the basis of the same criteria in appendiceal cancer, and also a survival that can be considered interesting given that it's beyond the second line and for a pathology where we don't know so much about what we should use in systemic chemotherapy. Also, Dr. Hübner drew that in another Nature Primers review we did. So this is a way to articulating different treatments, systemic and intraperitoneal, different types of intraperitoneal, can be HIPEC, PIPEC, and catheter-based chemotherapy, IP chemotherapy, in the setting of different peritoneal mets, including colorectal peritoneal mets. So the take-home messages I would retain from ISSPP when we discussed all that, is that all patients with peritoneal mets should be discussed for surgery, depending on the disease extension, but HIPEC per se should be discussed case per case. If we decide to go for HIPEC, probably it would be a great idea to follow the consensus of the experts, so to use mitomycin C as a first choice. We now know, as Dr. Klempner showed as well, that the landscape of colorectal cancer gets richer by the day. We know more and more, and we should finally slowly find out how to integrate that into practice. And although the therapeutic options are growing, the peritoneum remains a particular model. And I will end it by thanking you for your attention with a few photos from the ISSPP.
Okay, thank you very much, Dr. Sgarbura. That was excellent. So maybe we'll look at a couple of questions. So I think one of them was like, if someone had CRS HIPEC with mitomycin C and they have a recurrence, would you recommend doing it again with mitomycin C in the second surgery?
There is there is some evidence based on that, but really the level of the evidence is not that high in order to provide with a definitive answer. What I would say is that maybe we should follow the expert consensus, even if that's not based on a very, very high level of evidence. What they propose is that if the surgeon in the tumor board decides to go for a HIPEC for the recurrence, a potential second line could be an association of cisplatin and mitomycin C.
Okay, thank you. And then the next question is, for patients with who were NED for a while and then Drucker and have low burden peritoneal disease, is it better to go straight to surgery, HIPEC, or to do systemic chemo? What do you suggest?
So very good question. This was for a while a reason of debate, usually between Netherlands and France. In France, we tend to do neoadjuvant chemotherapy for patients that are metastatic, even when the PCI was low. Netherlands has a different attitude, suggesting the peritoneal mets are a local extension of the disease and not a systemic extension. So I would say that except for very, very low PCI, which means like 2 or 3 nodules near the tumor, the evidence would still suggest we should probably go for chemo in the first place. And under Dr. Klempner's control, because he's still here, there is a new Foxtrot trial coming from the UK who showed that maybe I would say it's a signal, even in locally advanced colorectal cancer, sometimes it could be of interest to, so not on metastatic, but locally advanced, sometimes it could be of interest to use FOLFOX preoperatively.
Okay. I think there's another question. This person is really asking about one troublesome, 2.3 centimeter times 2.3 centimeter met in the peritoneum, whether that could be surgically removed. And I was kind of wondering, like what you said, what is seen on scans and imaging might be very different when you actually look inside, right? Do you want to comment on that?
I agree. So if we only have some radiological report, it's hard to decide. So we need to explore further, maybe do a laparoscopy to find out about the situation. After that, 2.2 on 2.2, of course, theoretically, that's resectable. Now we have to see the location, the report with different vessels, etc. So it's a bit more complicated than that into practice. But
okay,
it's up to you, of course.
Thank you for putting all the questions in chat. Keep them coming. From the PRODIGE 7 trial, do you think that then the more importance is for the cytoreductive surgery, or is it more of an effect of the oxaliplatin in the chemo that was used?
Sorry, so the question was whether the results in the PRODIGE 7 are related to surgery. Well, yeah. I would say the results are related to surgery because these are the best results we've had with cytoreductive surgery since the beginning of the procedure, and this under randomized controlled trials. So the survival we obtained through this trial are really, really good. So I would say definitely the quality of surgery is a must. And in this sense, the trial was a success because it eventually put surgery as a very interesting part of obtaining a good prognostic for these patients.
Okay, thank you. Okay, Dr. Hübner, you can go ahead.
So that's very good, and you can hear me. So I also have some problems with my voice. I apologize. So I will do my best. So I have a topic. It's the first time I'm talking about this. How can we involve patients with peritoneal metastasis of colorectal cancer in clinical research? But I think the question should be broader. How can we involve patients in many things of patient care, not only research? This is a very important question because the perspectives can be really different. It's very easy for me to share the doctor's view with you. We define successful surgery as a combination of correct indication, high quality surgery, of course, but also embedded in optimized perioperative care. And high quality surgery is typically warranted by long training, high volume, and lots of dedication. We had tremendous improvements of clinical outcomes through enhanced recovery pathways to optimize periop care, but somehow we still struggle sometimes to put the correct indication. So I think this is closely related to the topic of the talk. What do we consider as good outcomes in oncological surgery? So we want to have low complications, short hospital stay, good overall and disease-free survival. So these are typically our metrics, but indeed, and especially for patients with advanced disease, we can argue if shorter survival with good quality of life is not better than endless suffering. So here we truly have to have a discussion between doctors and patients. And look, this is quite normal in business. If you want to design a new website, first thing you should do is to ask your client. Same thing if you want to construct a new hotel. Of course, you should know what your clients want, because otherwise you will probably not have success. So should we really inquire what our patients need? Should we take a broader look beyond clinical and oncological outcomes and take into consideration social, cultural, professional, economic factors, and also the psychological and emotional side? I'm convinced that we should, because patients' need and treatment goals are largely unknown by clinicians. Patients' evaluation is frequently incomplete. It's a shame, but it's a truth. And the communication between patients and doctors is suboptimal. Just take a look at this shocking study published in the New England Journal of Medicine. 69% of lung cancer patients and 81% of colorectal cancer patients with metastatic disease under palliative treatment were not aware that the chemotherapy is not likely to cure the disease. Unbelievable. So, and this being said, if the communication is incomplete, how can we make sure that the standard treatment, what we consider as a standard treatment, does really fit to the needs of the individual patient? And we can avoid, and we should avoid the mistakes. So this is a study which Olivia shared with me, very interesting. The authors of this study dissected for breast cancer and nephrology trials, 44 studies. They sorted out 46 primary outcomes. And then they did an interesting thing. They asked 30 patients and 12 healthcare professionals involved in care of those patients, inquiring what they think of the primary outcome measures chosen by the investigators. 13 out of 46 were judged to be optimal. Meaning, in other words, the investigators got it wrong in 72% of cases of studies. Look at this. So we'll stop here because I saved my voice for a couple of minutes. So Mick Marshall was really very happy to hear what women want. So I would like this as well, but I'm as much interested in learn what our patients want. And so this is the rationale behind our prospective observational cohort study to assess patients' perception and preferences. So we brought together an international collaborative with 3 aims: to evaluate the patient in a more global way, to define preferences and set realistic expectations, and to evaluate perception and satisfaction of care and results. We have foreseen 4 different cohorts, and 3 are touching patients with peritoneal metastases, which is the topic of the webinar today. The 4th cohort, which is a kind of control group, concerns non-metastatic colorectal cancer. It's a quite ambitious project where we want to evaluate the patient in very different dimensions. You see the dimensions and the tests with estimated time on the left side, and we will then evaluate those things at different time points, outpatient setting, at discharge, and 30 and 90 days after surgery. We will ask our patients a lot, namely to invest at least 2.5 hours of their time. So here, patient involvement is very important. The study has been approved. The consortium is established. The online application is developed, and the pilot phase has started. And I hope to give more results in a couple of years. One of the problems for this kind of projects is lack of funding. We tried it in Switzerland, rich country, but we didn't get it so far. We tried it also in France with our French partners. And maybe some patient groups have ideas how to get alternative funding for those really patient-centered projects. The patient's view, much more difficult for me, of course, without those results to find out, and we are all in the same situation, but we are convinced that we have to go into direction, especially for patients with advanced disease, of patient-reported outcomes, not only pain, function, quality of life, but many other dimensions. And here I give lots of credits to my dear colleague Abdel Taibi, who is a surgeon in Limoges, who is reaching for the stars with his COMATE study. So he put together a study to define specific patient-reported outcome and experience measures for patients with peritoneal metastases. And when he started to do this work, he realized that we needed a different group of investigators for the study, namely patients, which appears quite obvious, but which is rarely the case. So here he had first to train a group of patient experts, which is quite a challenge in the field of peritoneal surface malignancies, because unfortunately prognosis is bad. So first part of the study, nice name, Pelops, where we formed 35 patient experts who helped us in the second part to define a set of 9 specific peritoneal specific outcome and 8 peritoneal specific experience measures. And of course, for new scores, they need to prospectively validate it. And here, this is the second phase, which is launched by a COMATE 2 study. Third project, just wanna share this beautiful picture. It's a consensus process on optimal endpoints in peritoneal disease, which is shared by Olivia Sgarbura. She's working very hard on it and pushing us to deliver, and she will make sure that we will get some results within this year. Challenges are multifold. Sometimes it's very hard for busy clinicians to find the time, to find motivation, and especially for those kind of projects, also to find money. So patient and public involvement, PPI, is of course urgently needed. And I just summarized a couple of points. It's kind of a brainstorming. We need you for better communication between doctors and patients, for optimal study design, for dissemination of knowledge. We need you to choose the relevant trial endpoints, to set priorities in research, for funding potentially, to help with patient accrual, tailored treatments, maybe even to help for physician well-being. Could also think of this. So we clearly need you to define together with us what really matters, and many more things. So PPI is a no-brainer. Definition of a no-brainer is an obvious choice or decision where you do not even need a brain to make this decision. Because what we want in the end is to bring the two perspectives together. We want to offer to you, to our patients, what fits best to your individual needs. So I would really want to reach out to you to ask you to give us a hand to do it better. And if you want to get in contact, please send me an email or get in touch with me by any other means. Thank you very much for your kind attention.
Yeah, Dr. Hübner, thank you very much for that. And it's really important for us to know that these initiatives are going on. And related to that, like I would have one question: is when you look at peritoneal mets. One of the problems that we see is like the detection of them, right? Like if you're lucky enough to have surgery and they find peritoneal mets, then you have peritoneal disease. But for many patients, until it becomes really widespread, you don't come to know of it, right? So I was kind of wondering, what kind of things are being done to improve the detection rate? That's the first question. The second thing is, from the patient perspective, if you're an early or metastatic colorectal cancer patient, and right now you don't know that you have peritoneal mets, what are some of the things to keep in mind so that you can check back? Like, for example, mucinous tumor or signal cell disease, or, some particular mutations. Like, what are those factors that would make you go back to your care team and say, I want to check, or I want to make sure that I don't have new peritoneal disease? This would be a question for the entire panel.
I will try my best to give you a brief answer to this very complicated and complex question. So we have considerable improvements in the imaging techniques over the last years. So it has become much better, and in expert radiological hands, in expert centers, the imaging has become quite good. So we cannot state anymore that imaging is useless for detection of peritoneal mets, but it's really specific for expert centers. The big then question still is, do we need in high-risk populations second look laparoscopy? We don't know. We don't know. It makes perfectly sense with the two rationales. Frequently, early disease is not detectable by even modern than imaging, and we can treat this disease then only with decent chances if we detect it earlier. So clearly, there is a rationale for second look laparoscopies. Trials which investigated this strategy failed to show improvements in survival. So we have to acknowledge this, and we do not even know when the good moment is to do a second look laparoscopy. So is it directly after the adjuvant chemotherapy in high-risk patients? Is it 3 months later? Is it 6 months later? We do not know. We do not know. We have a study performed. The results are not published yet, where we then elaborated kind of a score to define the optimal moment for second look laparoscopy, but we do not know. So in concrete terms, in patients with high risk constellations, T4, perforated tumors, synchronous resected peritoneal mets, and ovarian metastases, at least in young patients, I would suggest to do a second look laparoscopy within 3 months after the end of adjuvant chemotherapy.
Okay, thank you very much. The other members of the panel, do you want to add something to it?
In terms of radiological imaging, many of the radiologists are also working on radiomics, as hoping to be a little bit more exact on the detection of this peritoneal mat. So that's a sort of molecular testing, but in radiology. So hopefully this will help us even more in the future.
Okay, Dr. Klempner.
Yeah, I think I share the opinion of everybody else. I've, over the years in gastric cancer, come to appreciate the information that comes from laparoscopies a lot. And I think it's, compared to many other procedures, relatively less invasive. So we think about repeating diagnostic laparoscopies when it might change how we think about the next steps. But I think it's definitely a tool that we use when we have limitations of the imaging. I know that our group here is looking at MRI PET as another tool, and doing, instead of a PET CT, doing an MR PET. Some of the radiologists have told me they think that it allows them to detect peritoneal things a little bit better, but it's still a big unmet need.
Okay, and then this is like a low-level question. Like, what about CA19-9? Do you guys like to use that? How does that reflect peritoneal disease better than CEA? Do you have any comments?
I'm not aware of anything that says it's better at peritoneal disease than CEA. I think some tumors make CA19-9, some make more CEA, and so whichever one is elevated or both, we will just follow routinely during any form of therapy, whether it would be high PEC or systemic chemo.
Okay. So we can go to the next speaker then, and then look at all the questions together. Thank you, Dr. Klempner, for answering the questions in chat. Yeah. Do you have to leave now?
Yes, I have a 1 o'clock patient, so unfortunately I do need to leave.
Okay, thank you very much. Thanks for joining and for the talk and answering all the questions.
Yeah, this was great. I look forward to seeing you guys at the next one and hopefully in person for some of you.
Yeah, I'll have the video up on CTU and I can send you a link. Okay, thank
Awesome.
you. Okay, we can go to the next, Dr. Gongura.
So yes, so hello again, everyone. It's again a pleasure for me to present the new research model for advancing treatment. So, so before describing the new models that have been developed, I wanted to share with you the condition on how to develop such a model. So it is important to know that predicting the efficacy of anti-cancer therapy is actually the holy grail of drug development. And to achieve this goal, researchers require preclinical models that can screen anti-cancer agents with robust clinical correlation, of course. So the research community tried to develop models that can accurately capture the diversity of a tumor ecosystem and to predict how tumor will respond or resist to a treatment. And the most important to take into consideration is that the tumors are made up of a heterogeneous landscape comprising malignant cells, obviously, and normal and abnormal stroma, immune cells, and dynamic microenvironment containing chemokines, cytokines, and growth factor. So thus for cancer research today, we must develop patient-derived models. So these patient-derived models will introduce inherent biological complexity, will preserve the intrinsic dynamism of a cellular heterogeneity and maintain the three-dimensional architecture of a native tumor. So such a model will lead to improved strategy for drug development. So the patient-derived model consists in using a patient biopsy to perform different experimental approaches, including DNA-RNA extraction for whole exome sequencing and RNA-seq, the patient-derived xenograft, patient-derived organoids, organotypic tumor spheroid, and organ-on-chip. So what I wanted to do is to give you some few examples of these experimental approaches, focusing on very recent model and results. So I will start with RNA sequencing of clinical samples. So the RNA sequencing, maybe as you all know, consists in extraction of RNA from the tumor samples and to sequence it in order to obtain the relative expression of genes of these particular samples. And I wanted to share with you a publication that Dr. Klempner already presented in a previous presentation. So the team of Vermeulen, so the Dutch team has performed this experiment, this RNA-seq on tumor from 52 patients in order to obtain molecular characteristic of colorectal cancer peritoneal metastasis. So before showing the result of this publication, it is important to know that colorectal cancer has been classified in 2015 in 4 different consensus molecular subtypes, depending on their transcriptome analysis. So CMS1 is MSI immune subtype, CMS2 is canonical subtype, CMS3 is metabolic subtype, and CMS4 is mesenchymal subtype. So this molecular classification is the basis for clinical stratification, as you can see here. So depending on the classification of the tumor, the survival probability will be different. So this molecular classification is also the basis for subtypes-based targeted intervention. So Vermeulen team did the exact same classification and reveals that colorectal cancer peritoneal metastases are mostly CMS4, as you can see here. They represent 85% of this subtype in the pool. And moreover, they were able to to divide it in 3 separate categories, this CMS4 subtype, and they called it PM A, B, and C. And these categories are, again, the basis for patient stratification and to define patient at high risk. And indeed, this group shows that the CMR4, PM A and C, sorry, I don't see it very well, A and C have a better prognosis as a CMS4 subtype PMB. So to continue on the models that can be set up with clinical samples, there is also the graft of this clinical sample into mice, and this is called PDX for patient-derived xenograft. The main advantage of this model is to properly represent the tumor heterogeneity, but they have several flaws, like there is no immunotherapy can be tested because we have immunodeficient mice, and it is not possible to perform high throughput screening. So other models are in vitro culture model. So PDO, RTS are organ on chips. So PDO are patient-derived organoids, and the tumor is dissociated and culture in a semi-solid matrix, and generally is matrigel in presence of high concentration of growth factor and 3D culture. The important thing of this PDO is that it keeps the endogenous architecture of the tumor, the cancer heterogeneity, and it displays the exact same driver mutation. But it does not retain the stromal cell, which is a problem. So concerning the OTS, organotypic tumor spheroid, it is the same thing as organoid or PDO, but this time with the addition of stromal cells. And I will give you one example in the next slide. And finally, what we can do also with patient-derived model is organ on chip, and it consists in recovering tumor slice, and we loaded this tumor slide on a chip, and this chip can monitor some biological parameters. And this model is the only one that preserves the 3D environment of the native tumor, but the problem is it doesn't last long, so we cannot keep it more than 1 week. So as I just told you, I wanted to show you some new results concerning the OTS, organotypic tumor spheroid, and by showing the recent work of the team of Konstantinos Votanopoulos. So this team has created a procedure to produce some patient-derived organoid with immune cells. So what they have done is that they have take the tumor cells and they perform tumor cell isolation, and they culture them in organoid, in matrigel, and these tumor cells then mix it with the immune cells, either from the blood of the same patient or with a lymph node of the patient, and they co-culture them at least for 7 days, and then they treat this PDTO with different drugs and especially with immunotherapy. And then to look at the drug effect, they can see with immunofluorescence or cell viability assay. So in this work, Votanopoulos compares the efficacy of 3 different immunotherapy. Here, I don't know if you see it, pembrolizumab, ipilimumab, or nivolumab, which are 2 anti-PD-1 or 1 anti-CTLA-4 on 6 different patients. And for instance, we could see here, in a patient 4, that when we mix the tumor sample with immune cells, either from a lymph node or from blood, and treated with here is pembrolizumab pembrolizumab has a high efficacy on this tumor compared to nivolumab that has no efficacy at all. So this IPTO and this work of Votanopoulos' team shows that this model allows preclinical testing of immunotherapy on patient samples, and this model is a real asset for personalized research. So to finish, I wanted to share with you a model that we have developed in a team with the help of Dr. Sgarbura. And this is a syngenic orthotopic tumor graft into immunocompetent mice. So a syngenic graft means that we graft murine cells into a mouse of the exact same genetic background. So this means that the mice will be fully immunocompetent. And this makes this model really relevant for studies of immunotherapy. Orthotopic means that the graft of tumor cells is into the corresponding tissue, here's the peritoneum, and this will make the tumor cells growing in a relevant tissue microenvironment. And the monitoring of the tumor progression will be done by two ways. First, with bioluminescence, and also by assessing the PCI score on the mice, exactly the same as it is done in the clinic. So in the lab, what we have identified a new protein, a kinase, which is called ATR, and which is responsible for oxaliplatin resistance. And we have shown that if we combine an inhibitor of this ATR kinase, that we call ATR inhibitor, with oxaliplatin, the combination is highly synergistic, as you can see here. And we demonstrated that the combination of oxaliplatin and ATR inhibitor is able to kill the tumor cells, but also is able to induce anti-tumoral immunity. So with this result, we raised the hypothesis that we may improve treatment by a new therapeutic combination, including oxaliplatin for a standard chemotherapy, ATR inhibitor to limit oxaliplatin resistance, and immunotherapy immune checkpoint inhibitor anti-PD-1 that will fortify the immune system to eradicate tumor. So we injected the murine tumor cells into the peritoneum of the mice, and we treated the mice with a combination of oxaliplatin, ATR inhibitor, and anti-PD-1. And here is the result. So here is a non-treated mice group, and here is the mice treated with the combination. And as you can see here, we cannot detect any more tumor growth in this group. So we continue. So now what we are doing is we trying to understand the role of the immune system on the efficacy of this treatment. And with Dr. Sgarbura, we are creating IPTO to test this treatment on clinical samples, on patient samples. So with this result, I will hand out my presentation, and I will be happy to take questions. And thank you very much for your attention. Thank you. Goodbye.
Dr. Gongura, thank you very much. So I think the next question that we would ask is like, from your disease, from your preclinical models, is there a pipeline so that you can move it towards a clinical trial in patients?
Not yet, I have to say. So it's still.
But in your consortium, it would be great to have like the next step of whatever is promising in mice models, that you can move it forward to clinical trials, right? Like with the oxaliplatin and ATR inhibitors and anti-PD-L1, that'd be like a great model to test on a small phase 1 trial or something.
I totally agree. I totally agree with you.
Okay. And then, I was really interested in Dr. Hübner's, comments about the repeat laparoscopic, look to see if, say, early stage patients after adjuvant therapy, whether they are likely to develop peritoneal mets. I was kind of wondering, what would be needed to have a trial like that, like for early stage patients, with the main idea, where you pre-select a high risk population and then have trials where you're doing laparoscopy look and then doing peritoneal washes and ctDNA or something like that. I mean, what can we do to, facilitate a trial like that, like as from the patient, from our side, because that would be very useful, right? Like detecting these disease, peritoneal mets early when people can do HIPEC and, change the, the course of the disease, right?
Yeah. So what we know is the most important risk factors for development of peritoneal metastases. So this we know, but we don't know what to do with these patients. And two large-scale randomized trials failed to prove benefits of a prophylactic or an adjuvant strategy. So we have the Dutch Colopec study, which applied the prophylactic IP chemo as HIPEC in high-risk patients before start of adjuvant chemotherapy, and the Profilogip study of the French consortium did it after adjuvant chemotherapy, and both studies were negative, meaning that the treatment arm, which had both, the second look, at least in the Profilogip, it was after adjuvant chemotherapy, and prophylactic treatment failed to translate into survival benefits. So we clearly don't know. I think we have to continue to investigate this, also to correlate circulating tumor DNA with results of staging laparoscopy, with tumor markers. We have to take everything we have, probably also use artificial intelligence to capture those factors which are not currently taken into consideration. But as of now, I don't think we can give an answer. Okay. What are your thoughts, Olivia? So do you have more insights? Second look laparoscopy.
No, I completely agreed with the clinical setting in which you proposed it earlier on. I agree with your interpretation on the trials. There is another proposal of trial in France. We're trying to do it with a slightly different scenario. We'll see if it gets funded next year. So we need to find out more about that before proceeding.
Okay. We are getting close to the end of the talk. Let me see if there are any other questions. So I think there was a recent paper where they were comparing, like, say, for example, the BRAF subgroup and then HIPEC and the results from that, right? So I was kind of wondering, even in the subgroup where, based on older studies, you would say that you'd probably not recommend HIPEC. Are there other factors to substratify patients? Even if you have, like, say, for example, a BRAF mutation, but you have continued stability on a certain treatment, or, what other factors could patients know about that would help them say, okay, at this time in my treatment, maybe now is when I should, pursue HIPEC and see what my chances are. I mean, what comments do you have?
Ladies first.
So basically, we would not exclude a patient for cytoreductive surgery and HIPEC merely on the criteria of BRAF mutation. But as you mentioned in your question already, so we'll probably take extra care when selecting these patients for operation. Some of these BRAF mutated patients are patients with mucinous adenocarcinoma, so probably we'll tend to take on cytoreductive surgery for BRAF mutated mucinous adenocarcinoma, but we'll be very careful with the selection, with the PCI and other conditions, with the response to chemotherapy. And probably Dr. Hübner would say more also about a score they developed in Switzerland based on that.
So basically, BRAF mutated patients, most of them do not benefit of CRS and HIPEC. So just to make it clear, the main treatment is cytoreductive surgery. And HIPEC is just an adjunct treatment, so we shouldn't talk about HIPEC, but really a CRS plus minus HIPEC. This being said, I would not exclude categorically BRAF mutated patients, because if for then any reason they have favorable then evolution, and if they fit resection criteria, and if they agree to take the risk of the procedure, they might still be candidates. But overall, BRAF mutated patients are no good candidates for this morbid procedure.
Okay, thank you. My other question was about, I think the PCI score, how it is looked at in Europe versus US is slightly different, right? I've heard that, the surgeons in Europe are a little bit more lenient. Is that true, or is that, we should have probably asked when Sam was here.
No, I would not say that. Well, we have clear criteria for calculating a PCI score. Now, there are always questions about how we can do it better. And several years ago, there was a tentative for a consensus on how to quote situations that were a little problematic. Unfortunately, I did not see the result of that consensus published to say that now everybody around the world is quoting the same thing. I would say those who quote a little bit different are usually Asian surgeons, because they don't usually use the PCI score, but a rather P1, P2, P3 classification, and that's mostly for gastric cancer. I don't know, Dr. Hübner, if you've got any other opinion on that.
Well, PCI is quite complicated and it's highly subjective, but it works incredibly well. It's a very useful tool for decision making and also for prognosis. So despite all limitations, I don't think that there are too important variations around the globe, and it works really well in clinical routine.
Okay. The other question is like a second HIPEC or second cytoreductive surgery, what are the indications where you would think that that is something that is realistic to do? Like, for a patient, what advice would you give them? When can they think of a second CRS kind of surgery?
You are first now.
Well, I should probably take this question because I was chairing the subgroup committee of the PSOGI consensus on those questions for colorectal. There was a weak consensus that redo CRS HIPEC could be considered for early recurrence, defined as occurring so within the first year after index surgery, but a very strong consensus to offer redo CRS HIPEC for patients with late recurrence occurring later than 1 year. This is an expert consensus, and unfortunately, we have very weak evidence to support either decision.
Okay. So this is a tricky way of me asking this. In your personal practice, what are the things that you would do? Like, I mean, apart from what is in the consensus, like what, when you have a patient in front of you, what are some of the things that make you decide that, okay, I'm going to do a CRS on this patient? What would those be?
So I'm a strong believer to walk the talk, and so if I am implicated or even chairing a subgroup for consensus, we should stick to the final result because otherwise it really doesn't make sense. So until we have better evidence, so I would explain limitations, hopes and risks of the different treatment options. We have to do it always. So what are the possible treatments with risks and benefits, and then let the patient decide. And some patients, so this is also an open issue, some patients want to be guided, and some patients rather want to guide the clinician into the direction that they want to have them. So here it clearly depends also on communication, but it's my duty to explain in a neutral way the available then alternatives, and then if the patient fits so within our agreed standards, then I would offer this treatment option.
Okay, thank you. Dr. Sgarbura, do you have anything to add?
Yes, I would say I agree with walking the talk on most of it. I would be a little bit more reluctant to say, yes, I would do cytoreductive surgery in HIPEC for early recurrence. because early recurrence, sometimes it's a sign of high activity of the disease. So we would normally not want to operate when the disease is very active in order to not see it recur again very quickly. So probably for these patients, I would take extra care to see that, I don't know, systemic chemo worked, maybe have a longer systemic chemotherapy, not after a short interval, but rather after a long interval. Discuss also the decision with the patient.
Okay, so the last question would be, in a palliative setting, what are the things that you would think about doing CRS surgery? Would you consider it at all?
I would say in the palliative setting, I would say the more important is to provide a very good quality of life to our patients, maybe with, let's say, at least equal survival results. So probably it's important to discuss the decision with them, but also to really take into account all the options that could provide with better quality of life than the one of palliative surgery that can involve a lot of morbidity and a lot of risk for the following months. So I would say that probably it's the setting where, for instance, PIPEC or an association of PIPEC and systemic chemotherapy might probably work better than palliative surgery. I don't know what you think, Martin.
So what is palliative surgery? I'm not convinced that we can take it as binary variable, yes, no. And most of so-called curative surgery, like curative pancreatic resections for pancreatic cancer, we know that that nearly all patients recur. So despite complete resection, so we could also label this as palliative surgery. So I think this is very difficult to say. CRC-Peri is not more morbid than other major than oncological procedures, and despite the fact that it's for metastatic disease, the outcomes are better than, for instance, for curative resection of pancreatic than cancer. So it has to be put into perspective, and those terms have to be carefully discussed with the patients, because if you mention palliative, many patients will be shocked. If you say curative, you give false expectations and false hope. So it's not so easy, and I would really be careful with those terms.
Yes, I agree that actually probably we answered to two different, or I don't know, clinical situations. So for me, palliative in that setting would be like a partial surgery, like a debulking, like something aiming to reduce the tumoral load. But I do agree that that's a case-by-case scenario.
Good. So debulking surgery can make sense in symptomatic patients, especially, but certainly no IP chemotherapy, no HIPEC.
Okay, thank you very much. I think we are at time, and this was wonderful. Thank you, Laure, for organizing it. And thank you, Dr. Sgarbura, for assembling a great team. And thank you very much. So once I have I'll edit the video a little bit, and then I'll have the recording on CTU, and I'll send you the links. Thank you very much. Thanks to everyone for attending and for all the great questions.